Hello, and welcome to the Annals Animated, our video look at an important paper published in Annals of the American Thoracic Society. Today we take a look at outcomes after video-assisted thoracoscopic lobectomy versus open lobectomy for early-stage lung cancer in older adults by Nicole Easer and colleagues. In patients with early-stage non-small cell lung cancer, or NSCLC, open lobectomy and video-assisted thoracoscopic surgery, or VATS, have demonstrated similar long-term survival. Both surgical approaches have become standard of care. However, previous meta-analyses, including a 2013 meta-analysis of observational cohort studies evaluating patient outcomes, found that VATS lobectomy was associated with a lower risk of postoperative complications and better long-term patient survival compared to open lobectomy. Thus, VATS has been increasingly used as treatment in early-stage non-small cell lung cancer based on meta-analyses of observational studies, despite the lack of supporting evidence from randomized controlled trials. More recently, a 2017 multi-center randomized trial examined short-term outcomes in VATS versus open thoracotomy for treatment of early-stage non-small cell lung cancer, and found that operative time and intraoperative blood loss in patients who underwent VATS lobectomy and mediastinal lymph node dissection was significantly lower than in patients who underwent open lobectomy and lymph node dissection. Despite this data, there have been questions about whether the improved perioperative outcomes and perioperative mortality may be related to surgeon characteristics, such as subspecialty training and surgical volume. This well-designed study takes a deeper look at this question and builds on the recent RCT that favors VATS over open lobectomy for early-stage non-small cell lung cancer treatment. In this study, Easer et al. Used SEER Medicare data to evaluate whether surgeon characteristics such as thoracic surgery specialization and higher surgery volume may explain the improved perioperative outcomes in older adults that have been associated with VATS lobectomy in previous studies. The Surveillance Epidemiology and End Results, or SEER program, includes data from cancer registries that is linked to Medicare data, that includes claim information for an individual from the start of Medicare coverage period to time of death. The SEER Medicare database is a publicly accessible database that enables investigators to use two large population-based datasets to conduct studies that provide data on long-term outcomes. Study investigators used SEER Medicare data to identify adults older than age 65 diagnosed with histologically proven stage 1 or 2 non-small cell lung cancer between 2000 to 2009 who underwent lobectomy. Those without Medicare Part B coverage and those enrolled in health maintenance organizations were excluded because of incomplete claims data for these patients. Nursing home residents, those with centrally located tumors, and patients who were treated with preoperative radiotherapy were excluded as they may have been less likely to have undergone VATS lobectomy. Cases in which there was no unique surgeon identifier also were excluded, leaving data on a total of 9,508 patients and 537 surgeons, with 8,323 patients in the open lobectomy group compared to 1,185 patients in the VATS lobectomy group. Study outcomes included complications within 30 days of surgery, need for prolonged hospitalizations, defined as 2 or more weeks, 30-day reoperations, 30-day readmissions, perioperative mortality, defined as death from any cause within the first 30 days following surgery, long-term survival. Linear mixed models were used to evaluate differences in surgeon characteristics. Propensity score methods were used to reduce confounding that may have resulted in allocation bias. Cox proportional hazards models adjusted for propensity scores were used to compare survival. Study investigators found that patients who underwent VATS lobectomy were more likely to be older and female, with a higher median income. Also, the VATS group had fewer comorbidities, were more likely to have had preoperative testing with PET scan, mediastinoscopy, and endobronchial ultrasound-guided lymph node biopsy, and were diagnosed with T1 or N0 disease more often than patients in the open lobectomy group. These differences were not significant after adjusting for propensity scores, suggesting that the propensity score successfully controlled for confounding by these factors. Another important study finding was that VATS lobectomy was more likely to be performed by thoracic surgeons with higher surgical volume, but the investigators did not find significant differences in surgeon age, gender, or practice location between the open lobectomy and VATS groups. Several differences in surgical complications also were noted between the open and VATS lobectomy group, even after adjusting for propensity scores, surgeon volume, and surgical subspecialization. VATS lobectomy was associated with lower rates of cardiovascular complications, thromboembolic events, transfusions, extrapulmonary infections, prolonged hospitalizations, and perioperative mortality. VATS lobectomy patients had higher overall survival compared to open lobectomy patients when adjusted for propensity scores. However, after also adjusting for surgeon volume and surgeon characteristics such as thoracic surgery specialization, this difference was no longer significant. Study limitations include that this is another observational study with the possibility of confounding by indication. However, the study investigators used propensity score methods to reduce confounding and mimic randomization. This methodological approach is a major strength of the study, setting it apart from previous observational studies. Another limitation is that these study results may not be generalizable to younger patients with early-stage non-small cell lung cancer. However, as the authors point out, lung cancer is more commonly diagnosed in older adults. So what does this study add to the scientific literature? This study further supports findings in previous observational studies and meta-analyses that VATS lobectomy is associated with lower risk of perioperative complications and perioperative mortality than open lobectomy in patients older than 65 with early-stage non-small cell lung cancer. The large number of patients included in the study and the generalizability of the results to the Medicare population in which non-small cell lung cancer is diagnosed are major strengths of the study. Furthermore, it demonstrates that surgeon characteristics such as thoracic surgery specialization, surgical volume, and practice location do not account for the improved perioperative outcomes observed between treatment with VATS lobectomy and open lobectomy. Despite this study not demonstrating an overall survival benefit with VATS lobectomy compared to open lobectomy in the treatment of early-stage non-small cell lung cancer, this study may have important implications for supporting VATS training and the use of VATS lobectomy by general surgeons and thoracic surgeons given the associated improved perioperative outcomes. For additional details, please read the article by Dr. Easer and colleagues in the February 2018 edition of the White Journal. Thank you for watching Annals Animated.